Bismillahirrahmanirrahim. Welcome to the sixth video about the hyponatremia, and in this one we are going to talk about SIAD or SIDH as it used to be called before. So this is a quiz from the last video. Again, if you haven't seen it before, you can pause the video and try to answer the question before we get to the answer and the discussion. So this seemed to be a case of Druginduced hyponatremia. So this lady, she's elderly. She has some risk factors to have poor nutrition and poor diet because of the recent death of her husband, and she's living alone, so she might not be able to have proper nutrition accordingly. Yeah, she's also presenting with vague symptoms that could be caused by hyponatremia. Her sodium is 122, and she appeared to be euvolemic. She's not tachycardic, but vital signs are okay, and mucous membranes are moist. Now, when you look at the urine osmolality, it's in the lower side, but it's still above 200, and urine sodium is also low. So that makes SIDH unlikely. We know that in SIDH, the urine osmolality is expected to be a little bit higher than this, and the urine sodium is also high, usually more than 20 or 30. And we're going to talk about SIDH in more details in this video. In primary polydipsia, yes, this patient might have some psychiatric illness in the form of depression, maybe, although this is not very quite obvious. But I expect the urine osmolality to be much lower. Usually it's less than 100. Although the urine sodium being low is compatible with that diagnosis. But I expect the urine osmolality to be much higher. I need more significant psychiatric history to make this diagnosis. Hyponatremia can present with a similar picture, although also in urine osmolality I expect it to be in the lower side, maybe close to 100 or 200. And also there would be significant history of alcohol, which is not the case here. So this is most likely Druginduced hyponatremia. The patient is not taking much solute, and that's why she's not really excreting much solutes in the urine, and that's why urine sodium is low and urine osmolality also in the lower side. So in the last video we talked about some of the causes of euvolemic hyponatremia. We talked about the causes that are usually associated with low urine and osmolality and low urine sodium. So in this video we are going to talk about the other causes of euvolemic hyponatremia, SID, and this is usually associated with increased urine osmolality and increased urine sodium. SID et al. Is just, or SID associate just means that there's other clinical syndrome that might look like SID, and we talked about that in the previous videos. In the last video, we talked about the basic pathophysiology of ADH or ABB or vasopressin. We're not going to discuss that again. If you want more details, please go back to the previous video. We talked about the secretions of ADH. We talked about the actions of the ADH. We talked about the factors that stimulate synthesis and secretion of ADH, and we talked about the factors that actually decrease synthesis and release of ADH. These are really important to know before you kind of understand the basic pathophysiology associated with SID. Now let's talk about the diagnostic criteria of SID. That's really important. There are 5 major criteria. All of them should be present to make sure that you or to be confident that the patient is having SID. This criteria is actually old and it hasn't changed much. Originated by Parter and Schwartz in 1967. So the first criteria is decreased plasma osmolality, and that indicates hypoosmolar hyponatremia. We talked about that in the previous video, that one of the tests that you should probably do initially is to not to rely on the calculated osmolality, but to do a measured osmolality, meaning to send the serum sample for the lab to specifically measure the serum osmolality to make sure that it's hypoosmolar. Because if there is true hyponatremia, the osmolality should be low, because sodium is a major electrolyte in the extracellular fluid. If that's not the case, if the measured osmolality is normal or high, then that indicates there's other, it's not true hyponatremia, there's something else going on. If it's hyperosmolar, this could be from hyperglycemia or any other osmotically active substance. If it's osmolar, this could be a pseudo hyponatremia, and we talked about that before in the previous video. So this is the first criteria. Plasma osmolality is the measured, specifically the measured plasma osmolality is low. The second criteria is inappropriate concentration of urine. So the urine osmolality also would be high, so the urine would be concentrated, and the specific gravity of urine also would expect it to be high. They correlate with each other. Why is it inappropriate? Because the plasma osmolality is low. If the plasma osmolality is low, you expect the urine osmolality to be low as well. And if the plasma osmolality is high, you expect the urine osmolality to be high in a normal kidney. So if that's not the case, this is inappropriate response. And we talked about the triggers of ADH. We talked about hyperosmolality being a potent stimulator for ADH synthesis and secretion. And that's because ADH will cause water retention to dilute the osmolality. But if the plasma osmolality is low and there's still increased ADH, this is inappropriate. So that's why it's called inappropriate SID, or inappropriate secretion of ADH. This is the second criteria. The third criteria is increased urinary sodium excretion. That's partly because of the water retention due to the action of ADH, but also because of sodium loss. There is natriuresis mechanism that happens with SID. We'll talk about that in the next slide. The fourth criteria is patient usually clinically euvolemic, but sometimes they might be even a little bit mildly hypervolemic because of the water retention that's happening as a result of the action of the ADH. We talked about the assessment of volume status. We talked about the fact that sometimes it might be difficult, so you have to take a good history, do good physical exam, and consider using point of care ultrasound, and look at the other labs as well. And then the fifth criteria, the last one, is to have to exclude other causes of euvolemic hypoosmolar hyponatremia, and this may include hypothyroidism. Usually hypothyroidism as a cause of hyponatremia occurs only or usually when it's really severe. So most of these patients will have some clinical features to suggest hypothyroidism. They will be maybe having some confusion, bradycardia, cold incontinence. So they might have really some manifestations of severe hypothyroidism to be reliable to call it as a cause of hyponatremia. Adrenal insufficiency, specifically secondary adrenal insufficiency, also might mimic SID. And because of these two, most experts recommend checking TSH and serum cortisol in any patient before you make the diagnosis of SID. We talked about the diuretic use and the loss of salt in the urine and how it can sometimes mimic SID. Although sometimes a patient who have excessive use of diuretics, they might be hypovolemic rather than euvolemic, but sometimes they might be euvolemic and they might look like SID. And urine sodium and urine osmolality also will be high in these patients. Also, the osmolality and urine sodium will be high in the wasting syndromes, including the renal wasting, which is a little bit more common than the cerebral wasting. And these also usually a little bit hypovolemic, but also they can be euvolemic in some cases. So again, to make the diagnosis of SID, you have to keep these 5 criteria in mind. So remember them. I think this is probably the most important part of this of the discussion about SID. So let's quickly discuss the basic pathophysiology that happens with SID. So this is a normal situation. This is the intracellular fluid osmolality normal at 280, the extracellular fluid sodium normal at 140. So due to any of the causes of increased ADH, we have 4 common categories for the causes of SIDs. We're going to talk about that, but any of them can cause increased ADH. The vast majority of patients with SID, they have increased ADH, but not 100% of them. Some of the patients might not have an AD, by the way, but most of the time in the majority of patients they have increased ADH. And also somehow most of these patients also will have the thirst mechanism being not suppressed, meaning despite the high ADH they still have water intake. So there will be water ingestion and the ADH will be high. So the combination of these two, ADH, as you know, will increase the water retention by the kidney, and if there's water from outside, then this will lead to expansion of the intracellular and extracellular fluid. So the osmolality in intracellular will be low, and the sodium, because it's the main electrolyte in the extracellular fluid, also will be low. And that's why some patient might be mildly hypervolemic because of that. Now, the kidney will recognize that, and somehow there is a mechanism that happens inside the kidney to try to compensate for that and correct this by getting rid of salt and solutes and sodium and subsequently water to try to decrease the volume. That process is natriuresis. We don't know exactly why natriuresis happens. Some say because that the expansion of the intra and extracellular fluid will lead to increase in the glomerular filtration rate, the GFR. Also, this expansion might lead to increase in the BMP secretion, which causes natriuresis, right? So this ultimately there will be increase in the urine sodium, increased urine chloride, and also secretion of urate, and that has some clinical significance, as we'll talk. So this compensatory mechanism can a little bit help with reduction of the extracellular volume, but it's not going to correct it altogether. So after that, there's going to be another mechanism where the cells will excrete potassium and some other osmolytes like glutamate and aspartate, intracellular osmolytes, with the hope that when these osmolytes go outside, water will follow, and this will lead to shrinkage of the intracellular and extracellular volume. Another compensatory mechanism that the kidney is trying to make to kind of decrease the expansion of the volume. Now again, this will lead to some reduction of the volume, but it's not going to correct the whole process or the whole pathology, unfortunately. And after some time, there's another mechanism that might happen chronically, can happen after a few days, which is a AVB escape. Basically, because of the increase in the AVB or ADH, the kidney will realize that this is abnormal, and somehow there will be like some renal adaptation in the form of reduction or downregulation of the AVB or ADH receptors. So there will be like blunting of the effect of the ADH on the kidneys, and that will lead to less water retention, and thus will lead to increase in the water excretion. Also, again, to try to compensate more for the volume expansion. So this is a kind of in summary and kind of a simplify the basic pathophysiology of SID. Now this has some clinical implications, right? We talked about the volume status. In this patient, they classically described as euvolemic because of this compensatory mechanism, but sometimes they might still be a little bit hypervolemic, but that might not be clinically evident. And also loop diuretics can help with that, so they might decrease the volume a little bit. But also remember when we talked about the difference between thiazide and loop diuretics can blunt the effect of ADH a little bit, so they can help also with blunting the effect of the ADH on the kidneys. So they might have some therapeutic implications in patients with SID. Also, uric acid can be supplementary to the diagnosis of SID, so I like to check it, especially if I'm not sure about the diagnosis. It's usually low in patients with SID, partly because of hemodilution, but also because of the natriuresis and excessive uric or increased urine excretion in the kidney as a compensatory mechanism. So if you do the fractional excretion of uric acid, most of us are familiar with FeNA, or the fractional excretion of sodium. This is the same thing, but it's just instead of sodium, it is uric acid. It will be most of the time in the SID, it will be more than 12%, indicating there is increased excretion of urate or uric acid in the urine, supporting the diagnosis of the SID. It's not in the diagnostic criteria, the 5 diagnostic criteria we talked about, but it kind of is very helpful supplementally. And if you're not sure about volume status, you might think the patient might be a little bit hypovolemic, because differentiating hypovolemia from euvolemia sometimes, not always, sometimes might be challenging. So you might do like fluid challenge. You might give some little fluids over a few hours, and you check the serum sodium periodically. So in SID, usually the fluid will not help. It's still going to expand the volume. It's going to make the problem worse. Urine sodium natriuresis process will continue, and urine sodium will not change, and sometimes it actually might get a little bit worse. So once you check the fluid and you check the sodium periodically, you know that it's not hypovolemia, because the sodium is not improving. Compare that to hypovolemia, where you give fluids, the sodium will improve and the volume expansion will increase. But of course you have to be caution. You have to exercise caution here and be careful, because you don't want to make the sodium worse, and at the same time you don't want to make the hypervolemia worse. But you can do that if you're not really sure, but it needs close monitoring. So as you probably know, there are a lot of causes for SID, but there's 4 of them that are kind of the main 4 categories. So the first one is increased ADH because of ectopic ADH secretion, and most of the time that will be from cancer, and we're going to talk about that in a little bit more details. Also many drugs can also be associated with SIAD, some lung diseases and some pulmonary diseases, and we're also going to talk about that. So these are the 4 main categories. But there's other less common causes of SID. We discussed that in previous videos. We talked about the effect of nausea and vomiting, pain and stress on the ADH secretion, and how they can be triggers. With HIV also, AIDS also can be a cause of increased ADH. It's not quite obvious why, probably different mechanisms. But we know that HIV is one of the great mimickers, so I'm not surprised. Patient with marathon runners also talked about that. Stress can also, and excessive exercise can also lead to increased ADH. And also there is nephrogenic SIAD, which is basically when I mentioned that there's not 100% of the cases of SIAD as associated with increased ADH. This is one of them, maybe the main one. So there is levels of ADH, so the serum is not really detectable. Again, most of the cases of hyponatremia, we don't really check serum ADH. We talked about the fact that it's very short-lived, and it can go up and down, and it's not readily available anyway. So, but sometimes there's no increase in the ADH level in the serum, but there is actually mutations in the V2 receptors in the kidneys. And this will lead to false activation of the receptor, perceiving that there is ADH but there is none, and that will lead to ADH activity without an actual stimulation by an ADH. And this is one of the reasons, maybe that's why they shifted the name from SIADH to Syndrome of Inappropriate Anti-Diuresis, or SIAD, because they don't want to say ADH, inappropriate ADH secretion, because not all the patient has increased ADH. So just keep that in mind in case you might encounter some of these less common causes, or specifically this less common cause of SID as a cause of hyponatremia. Now, you still have to make some effort to try to figure out the cause and treat the underlying cause, because that's really the main treatment for SID. But at the end of the day, there is still many patients that might not be, or we might not know the underlying cause, and we call it, we don't know, idiopathic, whatever we like to call it. But again, you still have to make a little bit some effort to try to identify the underlying cause and treat it. So the first category is the malignancy-associated SIAD. The most common one is bronchogenic carcinoma, or small cell lung carcinoma. Is well known to excrete ADH, some of these cells are actually, they found them, they stand positive for ADH, but they might not secrete the ADH. So in other words, the most common malignancy associated with SIAD is lung carcinoma, but not all the lung carcinoma patients secrete ADH. So 75 to 80% of malignancies, if they are associated with SIAD, they're going to be bronchogenic carcinoma, and only 10 to 50% of small cell lung cancer, and only 1%, that's even lower, for non-small lung cancer to they develop SIAD. So remember, lung cancer is kind of the most common one, but it's not the only one. There's other malignancies like GI malignancies, uroepithelial malignancies, reproductive system malignancies, thymomas, lymphomas, leukemias. Unfortunately, the broad diagnosis, the differential diagnosis is really broad, but again, the bronchogenic is still the most common one. Also chemotherapy, a lot of the chemotherapeutic agents might be associated with SIAD. This falls under the drug-induced SIAD. We talked about the pain medicines, nausea and vomiting. Also, these symptoms are very common in patients with malignancy and could be contributing to the development of SIAD. So what's the workup? What to do about it? There is no strict single guidelines. It's really case by case. So you take into consideration the age of the patient, the gender of the patient, excuse me, and symptoms of the patient, family history, of course, and risk factors for certain malignancies. And the tumor marker is really questionable. We're still not really sure about the significance of those and how helpful they can be. You can consider them in some cases, but you don't have to order all of them in every single case. So again, it's case by case, but you always have to think about malignancy in patients with unexplained hyponatremia, and you think they might have SIAD, or they have or the criteria that we talked about to diagnose SIAD. The second category is drug-induced SID. There's the drugs can cause SID in different ways. Some of them stimulate the ADH synthesis and secretion by the posterior pituitary, as we discussed in the previous video. Some of them might enhance the ADH action on the kidneys, and most of them are actually unknown. And the most common medications are antidepressant, especially SSRIs, selective serotonin reuptake inhibitors, and these are more common in elderly, and they usually happen about 2 to 3 weeks after initiation of the medication or after increasing the dose, but it can happen anytime, unfortunately. And after you stop the medication, they usually resolve within a few days, but sometimes it might take a few weeks before resolution of the hyponatremia. Again, unfortunately, the list is really long. There's a lot of medication that could be associated with hyponatremia and SID, so you need to check the FDA label or the pharmacokinetics and the side effect of these medications. Pain medications, narcotics and NSAID, antipsychotics, anticonvulsants, especially carbamazepine. We talked about the chemotherapeutic agents in patients with cancer. Nicotine, ecstasy, oxytocin might stimulate the ADH action of the kidneys. Clofibrate and ACE inhibitors is known cause, but it's rare. So again, the list is unfortunately long, but some of these medications are more commonly associated with SID than others. So if you don't really know the cause and you're suspecting a particular medication, you can just stop the medication and follow up the patient and check the level afterward and see if there's an improvement or not. The third category is SID due to pulmonary disease. The most common pulmonary cause of SID is infections, and the most common ones are tuberculosis, especially in the developing countries, Legionella, bacterial pneumonia, and empyema. But it can happen with any other pulmonary infection. It's relatively common. Up to about 1/3 of the patient might develop SID and hyponatremia, but it's usually mild to moderate. Rarely you get severe hyponatremia due to pulmonary infection. There are some studies that suggest it might be associated with increased severity and mortality of the underlying disease. So if you have a patient with pneumonia and they have hyponatremia, you might need to be a little bit more attention to this patient. The mechanism, of course, unknown, but could be due to the hypoxia. Some theories suggest that the hypoxia stimulate the low-pressure baroreceptors and chemoreceptors found in the large vessels, pulmonary vessels, and the right side of the heart, and that might stimulate the secretion of ADH somehow. Also, the inflammatory mediators, especially interleukin 6 and 8, there's some theory that it might also stimulate the ADH secretion. Resetting of osmostat might also play a role, and that will lead to the brain recognizing that there might be a need for ADH secretion, but actually there's no need. Again, just theoretical assumption. Patient in the ICU, and they are put on positive pressure ventilation, they also can develop SID and hyponatremia. Patient with obstructive disease like asthma and COPD. And there is some study that suggests, just like a heart failure, there may be some association with hyponatremia and COPD in terms of prognosis. So, patient with persistent hyponatremia and they have COPD without other cause, they might be associated with worse prognosis. Of course, sometimes you need to rule out malignancy in patients who have COPD, especially they have risk factors like smoking. Patient also with cystic fibrosis, maybe bronchiectasis, also they might have some other association with hyponatremia and SID. So as you can tell, it's a lot of causes, but again, remember infections, especially bacterial infection and more atypical indolent infection can be associated with hyponatremia. Okay, so this is a last group, the fourth group that can be associated with SIAD, which is cerebral disease. So as you can imagine, there are many causes of or neurovascular causes of SIAD, including infections, meningitis, encephalitis, cerebral abscess, trauma or surgery, brain surgery, bleeding, intercerebral hemorrhage or subarachnoid hemorrhage, especially subarachnoid hemorrhage associated with rupture of the anterior communicating aneurysm for some reasons, multiple sclerosis or other demyelinating disease, inflammatory disorders, and porphyria. So basically most of the brain changes with brain pathologies, especially if they are severe, can be associated with SIAD. Mechanisms exactly unknown, but possibly due to stimulation of the hypothalamus to secrete ADH, synthesize and secrete ADH. I remember we talked about the nuclei that synthesize ADH are found outside of the blood-brain barrier. So it might make them more liable and to many pathologies. Increased BNP can be also a result of damaged brain due to these diseases, and this can lead to natriuresis as well, theoretically giving a picture similar to SID. Now, in the previous video, we talked about cerebral salt wasting, which is also a cause of hyponatremia because of underlying severe cerebral disease. But it's much rare, really. It's actually debated whether it exists or not, to be honest. But SID is much more common. But it's always, people always try to compare the two, and they try to make the distinction that you should be able to think about both. There is some similarities and some differences between the two, especially in the volume status. Cerebral salt wasting, because of loss of salt and volume, patient might be hypovolemic compared to SID, where the patient is euvolemic or again mildly hypervolemic. Urine volume is increased in cerebral salt wasting, again because of the wasting of salt in the urine and followed by water. In SID, it's not that affected. Urine sodium is high in both, but it's much higher in cerebral salt wasting, as you can imagine, because of loss of sodium in the urine. Uric acid also is low in both situations, but it's more commonly low in SID. And as you can imagine, most of these patients are acutely sick. So if they have severe hyponatremia, you need to be very careful. They need to be in neurocritical care or ICU, and you need to start the management by raising the sodium a little bit quicker than usual because of their instability. So you might use hypertonic saline in both of these situations if they're really sick. And then with cerebral salt wasting, you need to kind of re-expand the volume and give them fluid because they're hypovolemic. But in SID, when they are more stable, then you need to kind of do the management of SID, which we're going to talk about next video, and do some fluid restriction in addition to the other measures that are useful for SID. Okay, this is a quiz for the last just the last slide, so go over it, and then we're gonna start the last video about hyponatremia. We're gonna talk about the management, but we're gonna start with this quiz. See you then. Bye bye.